This presentation is about the Charcot-Marie-Tooth disease by Shelby Abbott, Rachel Ayers, and Kylie Grubbs. What is CMT? It's a genetic nerve disease that has over 100 known genetic causes. The onset is early adolescence to adulthood and can onset in babies too. The most common inherited neuromuscular disorder is CMT. It's characterized by degeneration of motor nerves and loss of sensation in the extremities. It's a progressive disease that has no cure. How was CMT discovered? It was named after Jean Martin Charcot, pictured to the side, and Pierre Marie and Howard Henry Tooth. Pierre Marie was Charcot's student, and they named it a peroneal muscular atrophy. And then Howard came in later and named it the peroneal progressive muscular atrophy. But together in 1912, they named it after each other, and they divided it into two different types in 1968. Through the years, these types have emerged into other types. On the side, I've created an umbrella with CMT in the middle because CMT is more of an umbrella term, because you can be diagnosed with any of these types. CMT1 with subtypes A, B, and many others. CMT2, CMT3, CMT4, CMTX, and dominant intermediate CMT. Each of these occur due to genetic mutations, and genetic mutations can alter the myelin sheath on the axon. When diagnosing CMT, doctors can do a nerve conduction study, which is pictured to the side on the leg, and electromyography, a nerve biopsy where you take a piece of the nerve and cut it up and then put it under a microscope and watch for any nerve degeneration in the axon. And you can also do genetic testing since it's the most prevalent genetic disease. Prevalence, it affects 150,000 estimated people in the U.S. every year, or not every year, altogether. It occurs in all populations and races. 1 in 3,300 individuals are diagnosed each year. In a study by Theodom et al. In 2019, he found that people between the age of 50 to 64 had the most prevalence for this disease, with 25.2 people per 100,000. And there's also more prevalence in males, with 16.6 per 100,000, and females 14.6 per 100,000. Symptoms in teens or young adults. Teens might have trouble with gripping, balance issues, shuffling the feet, cold hands and feet, numbness and tingling, which are due to nerve degeneration, curled toes, which is also called hammer toes, high arches in the feet. And the picture to the side is demonstration of normal arch versus abnormal arch after disease onset. Symptoms found in babies. They have trouble grasping or holding items. When it comes to development, they take longer to hold the head up, crawl, stand, or walk. They also fall more than average. Some less common symptoms are sleep apnea, problems swallowing, choking, hearing loss, scoliosis, which is abnormal curvature in the spine, pictured to the side, problems breathing, which occurs due to respiratory muscle weakness.
Okay, so treatment. As previously mentioned, there is no cure for CMT, so treatment is focused on helping individuals cope with the symptoms they're experiencing. There's environmental adaptations that can be made to their home and other places they might go. There's adaptive devices, and then it's focused more on maintaining mobility, flexibility, and muscle strength. Some adaptive devices could be ankle or foot orthoses, braces, and other orthopedic devices. And then adaptations are and modifications are to help or how a person perform tasks. And then here pictured are some adaptive equipment. A wheelchair and a walker, those are used to help with like fatigue and safety with transferring. Ankle orthotics, those are used for balance to help with foot drop and stabilization. And at the bottom, a wrist and thumb splint, those are helpful for fine motor skills of the thumb to help with the thumb and the fingers, and then wrist stabilization. And then with showering, you can get a shower chair to help with energy conservation as well as balance and safety precautions in the shower. There are scrubs typically that are helpful instead of, since they struggle with grabbing, they have handles a CMT patient can just slide their hands through. That back one is a long one so that it can get like places that are either on their back or lower down. And then with dressing, there's a button aid that helps to button shirts and stuff since they don't have the fine motor skills. They struggle with those. And then there's zipper aids. A person with CMT would, when buying jackets and stuff, these little loop things at the bottom, pictured at the bottom, would help them like just stick their finger through and pull their zipper up. And then these are some adaptive devices for eating. Most all adaptive devices you can find with a handle. There's one that you can use for a sandwich, one for a water bottle, and then there's some for utensils. Another thing for utensils is finding some that have bigger handles so that they're easier to grasp. And then 3 treatment goals for a patient with CMT. That these are just kind of generalized goals that a lot of patients with CMT have generally. So patient will be educated on the use of adaptive devices to increase functional participation in daily activities. Patient will complete grouping activities to improve fine motor skills, and patient will perform muscle strengthening and range of motion activities to prevent muscle atrophy and weakness.
This is a case study we made. It reads, Mr. Allen is a 25-year-old high school soccer coach that is recently divorced and shares custody of his 2 children. Mr. Allen began noticing weakness in his lower extremities and pins and needles sensations in his feet. His symptoms further progressed to balance and coordination difficulties and clumsiness, which led to Mr. Allen frequently tripping and experiencing injuries, such as sprained ankles. Mr. Allen decided to seek medical help when he was no longer able to lift his foot while walking, which is known as foot drop. After seeking medical help, Dr. Bones referred Mr. Allen to occupational therapy following a diagnosis of CMT. During an initial evaluation, the OT learned that Mr. Allen is now starting to experience symptoms in his hands such as numbness, muscle cramping, decreased sensation to temperature, and muscle weakness. After completing an occupational profile, Mr. Allen identified wanting to increase his independence in completing ADLs and returning to his job as a coach. Clinical reasoning to use would be narrative, which could be used by discussing meaningful activities, roles, and tasks that Mr. Allen participated in prior to diagnosis, and what he wishes to work on and expects out of therapy. So he listed coaching high school soccer, being active in his children's lives, and completing household management tasks. Also conditional reasoning, by recognizing that CMT is a progressive disorder that increases in severity over time, and therefore conditional reasoning would be used to develop an intervention plan that is focused on treating Mr. Allen's symptoms while also using those symptoms to determine future areas of improvement and impairments. So you can use the occupational adaptation theory to adapt how Mr. Allen completes ADL and work activities and make environmental adaptations and modifications as well. Some intervention strategies for Mr. Allen would be to do strengthening of the bilateral lower extremities and hands. This could be done by doing a home exercise program to maintain strength, range of motion, and mobility, as well as delay and reduce muscle atrophy. And also while in the home exercise program to do muscle and ligament stretching. The strengthening exercises will be beneficial with the contractures in his hands and his foot drop by strengthening those muscles to make them more functional. And then implementation and education of adaptive devices such as an ankle foot orthosis, thumb and hand splint, feeding utensils with straps, and shower bench, which are all things that Rachel already previously discussed, which would help him get back to safety and doing ADL activities and returning to work. And also modifying clothing, such as wearing shoes with Velcro instead of laces due to poor fine motor skills, and wearing pants with elastic waistband. Sensory integration and processing, so you could do tactile stimulation to enhance and reduce nerves' reaction to touch and decrease pain, which will help them to perform or help them to interpret sensory information to perform motor actions such as ADLs. And doing a home evaluation to remove trip hazards, install grab bars, and other things like that. Some goals for Mr. Allen would be using his ankle foot orthotics to improve balance. Mr. Allen will successfully walk across a 20-foot beam with no falls within 3 weeks. Mr. Allen will complete hand strengthening exercises with minimal rest breaks within 2 weeks. And Mr. Allen will don and off clothes using energy conservation techniques independently within 2 weeks.
Okay, so we've included a short video that's about an occupational therapy on a child. In your free time, you can go in and watch this, but this concludes our presentation on CMT.